Very good morning. I welcome you all for today's presentation, the serum markers of myocardial infarction. So once again, I thank the Quidel Ortho people for giving me an opportunity to speak a few things about the serum markers of myocardial infarction. So as we all know that the serum markers plays a critical role in the diagnosis as well as prognosis of myocardial infarction. Even though the traditional way of getting the ECG and other things is done with respect to the myocardial infarction, so the ECG changes and other things are done after the cause, and it is a consequence investigation that is being done. Whereas these enzymes, with the slightest of the clinical symptoms or the signs, what we observe in the patient. So when we do these biochemical markers with respect to the myocardial infarction, so we can do an early diagnosis and we can do an early intervention so that we can save the lives of the people. As we all know that the myocardial infarction happens in the golden years of the life, particularly around 40 to 50 years is the critical age where we see the chances of getting myocardial infarction, and particularly the temperature and various other environmental factors also plays a critical role, and also the dietary habits, the stress life and various other factors are also the causative factors in the causation of the myocardial infarction, whatever the reason it may be. So the serum markers plays a very important role and the critical role in early diagnosis and management of myocardial infarction. Next slide, please. So as we all know that colloquially, the myocardial infarction is also called as the heart attack by a vernacular language. It is caused by decreased or complete cessation of the blood flow to a portion of the myocardium. The decreased or complete cessation of the blood flow may be either because of the lipid accumulation inside the arteries, or maybe because of the compression of the arteries, or maybe because of the various changes that happens with respect to the vasculature of the coronaries and various other things. So it may go undetected, which we consider it as the silent myocardial infarction, or it may be the following the hemodynamic deterioration, which may lead to sudden death, which we call it as the catastrophic event. So there are two types that may happen. One is it may go unnoticed, that is silent, or it may be catastrophic event leading to hemodynamic and deterioration and death. Next slide, please. As we all know that the warning signs of the myocardial infarction includes the chest pain, particularly the retrosternal chest pain. Often it may be a vague symptom such as the low backache, or it may be the in between the scapula, the shoulder blades. The people may complain of pain, or they may complain of the abdominal pain, where we may get it confused with pancreatitis or maybe with gastritis, acid peptic disorders, even appendicitis for that matter, or intestinal obstruction and various other things. And these people will have cold skin with sweating, and there will be confusion, there will be altered sensorium, and there will be increased intestinal motility where there may be vomiting or there may be loose stools, passage of the loose stools. And these people will have giddiness and they will be under panic attack. And all these findings may be contributed either to the vasovagal stimulation or maybe due to the adrenergic drive that will happen in these people. And it is a sequelae, the myocardial infarction is a sequelae of the decreased blood supply to the cardiac muscle. So if at all, if there is any delay in the diagnosis, which may delay the treatment and may lead to the further damage of the heart muscle, where there will be anaerobic condition that will happen due to the blockage of the arteries, the coronary arteries. So the anaerobic glycolysis do happen, and there will be increased formation of the lactic acid, and this lactic acid may lead to the acidic change in the acidic environment of the vasculature as well as the muscular compartment of the heart, ultimately leading to severe pain that will happen in these people. And if the person is a diabetic, often he may not notice this pain, because as we all know that the diabetes masks the pain in case of the myocardial infarction. So, which ultimately may lead to go unnoticed and may lead to consequences such as the casualty and other things. The coronary artery disease is the main cause of the myocardial infarction, where there may be a partial block or there may be a complete block. There are three things that has been implicated with respect to the myocardial infarction. One is the lipid hypothesis. Second one is the oxidative stress hypothesis. Third one is the response to injury hypothesis. The lipid hypothesis, where we all know that it is the lipids that are the one that gets accumulated in the tunica media of the blood vessels, particularly the smaller arteries, the coronary arteries, where there will be increased LDL concentration, decreased HDL, where the reverse cholesterol transport and other things do not happen, and there will be formation of the atherosclerotic plaque with neovascularization there in the tunica media of the blood vessel, ultimately leading to tumorogenesis like pathology that is going to happen there, and there will be neovascularization, and ultimately there will be a bulge into the tunica intima, ultimately blocking the lumen of the blood vessel, leading to decreased circulation further. So this in turn will lead to decreased oxygen supply. Decreased oxygen supply and ultimately leading to anaerobiosis. So the further lipids that are involved in the causation of these things includes the lipoprotein A, the apoproteins that are tagged with the lipoproteins, the increased triglycerides, which may be a consequence of increased blood glucose, or may be due to increased consumption of the lipids that we regularly consume in our diet, or it may be because of the various other lipids that have been implicated with respect to the causation of myocardial infarction. So these things comes under the overview, the bird's view of the lipid hypothesis that has been implicated. The oxidative stress parameters, which includes the superoxide dismutase, malondialdehyde, nitric oxide, all these vitamin C deficiency, all these things will lead to increased hydrogen peroxide, ultimately getting broken down with the help of catalase this hydrogen peroxide into water molecule and superoxide oxygen, and the superoxide oxygen ultimately will go and bind with the PUFA that is there in the cell membrane, leading to PUFA superscript oxygen, that is the peroxyl PUFA to happen, and further hydroxylation and other things to happen, and then there will be lipid peroxidation there, and it is the oxidized LDL that will lead to formation of various other changes that will happen in the vasculature. Next is the response to injury factors, so which has been implicated purely to the hypertension. So people with hypertension do result in, there will be rupture of the, as I have told, there is the etiopathogenesis and other things do resemble that of the tumorogenesis there inside the tunica intima, leading to sudden gush of the blood in the coronary arteries, causing damage, formation of a clot. As we all know that if there is any damage to the blood vessel, so there will be bleeding, formation of clot, dislocation of the clot, blocking of the blood vessel further, and leading to decreased circulation. So this comes under the response to injury factors. Next slide, please. The symptoms of myocardial infarction, there is a slight difference between the males and females. So ultimately, whatever it may be, there will be shortness of breath, squeezing chest pressure, particularly the retrosternal, discomfort in arms, jaw or neck with cold sweat in the peripheries and limbs, and nausea and lightheadedness, unusual fatigue or fainting in case of females, and shortness of breath is common for both males and females. And this is the profile that we do with respect to the myocardial infarction, the 5 parameters that we do in the casualty once the patient comes. So usually it will be a point of care testing, and once we get to know about that, if there is any alteration or modification in the parameters that we do with respect to the shortness of breath, then we have to draw the blood and we have to send it to the laboratory for quantification, as well as to find the activities of the enzymes and various other parameters that we are doing with respect to the shortness of breath profile in the casualty or in the emergency medicine department. Invariably, there will be chest discomfort, but it may often go unnoticed in people who are already on proton pump inhibitors or H2 blockers and various other drugs. So there will be pain in the arm, radiating to the jaw, neck, upper back, and also to the abdomen in many of the cases. So we have to make a note here. For females, the symptoms of heart attack are more often confused with the anxiety, indigestion, or maybe because of the pleuritis, which is a consequence of the viral etiology. Next slide, please. The diagnosis of the myocardial infarction, there are two criteria that needs to be met. One is the ECG findings, the electrocardiogram findings that we do regularly once the patient complains of the chest pain and who are at risk and who are having a lot of the risk factors that we notice. The risk factors include the social factors, the economic factors, the professional factors, the environmental factors, all these factors with his habits and lifestyle that the person is following. If he is a smoker, if he is a heavy smoker, if he is a binge alcoholic, or if he is a diabetic, hypertensive with all the risk factors, family history of myocardial infarction, or in case of females, if the female is on oral contraceptive pills or various other drugs that they are consuming, if the person is on steroids, if the person is on hypolipemic drugs, and if the person hypolipemic drugs is an indication that the person had a very high cholesterol and triglyceride levels for which the statins has been started. So these are the people who are at risk in whom we need to think of, and the ECG changes plays a very important role as the first step in the management of myocardial infarction. I have shown here the normal ECG thing. So we can see here the PQR. Till here, it is the atria that it indicates. After that, the QRS complex with the T indicates the ventricles. So we have to calculate the RR interval. We have to check for the ST segment. And there are 5 types of changes that we can observe with respect to the ECG in case of myocardial infarction. So the ST to T changes are the one that we need to observe, and the deep Q waves are the one, or the tall R waves, and the QRS complex we need to calculate the ST elevation with a fall with a deep R wave, and the Q wave are the one that we need to see, and the J point is the one which is the beginning of the S to T is the J point. So these are the things that we need to check in. And the new STT changes are the left bundle branch block and the presence of the pathological Q waves on the ECG and an abnormal regional wall motion abnormality on imaging, where each lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6, each one indicates its own cardiac. Say for example, the septal defect, the inferior wall, the anterior wall, the lateral wall, or the posterior wall ECG changes we need to observe. So this gives us a clue as a first step. However, whatever the changes that we observe with respect to the ECG needs to be confirmed with respect to the biological markers or the biochemical markers, where it plays a mainstay in the diagnosis of myocardial infarction. Next slide, sir. What is the best indicator of myocardial infarction? In addition to the ECG, as I have mentioned, the enzymes in the serum plays a key role in the diagnosis of myocardial infarction. Particularly the troponins are the one which plays a very important role. In addition to this, the traditional markers such as the CKMB, AST, LDH also plays an important role. So these myocardial infarction markers can be classified under neurohumoral hormonal activation factors, myocyte necrotic factors, plaque destabilization myocyte rupture factors, matrix remodeling factors, inflammation oxidative stress markers, nucleic acid markers, and of late, we might have seen that the recent advances is that the microRNAs are the one that plays a very important role in diagnosis, prognosis, as well as with a strong family history of myocardial infarction, or people who are at risk can be diagnosed by doing these microRNA studies. However, at the present juncture, in any of the peripheral hospitals or the referral hospitals, so some of the parameters such as the NT-proBNP, troponins, AST, LDH, myoglobin, CKMB are some of the factors that will handhold the clinician in making a diagnosis of these things. Next slide, please. There are 2 types of myocardial infarction, where we can classify it as type 1 acute myocardial infarction or type 2 acute myocardial infarction. The type 1 myocardial infarction is caused by an acute atherothrombotic coronary event, which may be contributed to one of the 3 factors, such as the lipid hypothesis, oxidative stress parameters, or maybe because of the response to injury factors. So these are the 3 things that can be implicated with respect to either of the type 1 or type 2 acute myocardial infarction. The type 2 acute myocardial infarction is more heterogeneous entity, which is often very confusing for the clinician to make a diagnosis. Where here, the myocardial infarction, other than the coronary artery disease, which contributes to an acute imbalance. For example, it may be because of the homocysteine, oxidative stress and hypertension are the one. So the hypertension is the one that confuses the clinician. So when we ask the patient whether he is an hypertensive, usually the hypertension is an accidental finding that is observed by any of the clinician, or if the patient is having any symptoms of the hypertension such as the giddiness and other things, then only or by regular checkup that they get it done, annual health checkup or whatever the checkup they go for. So that time it is an accidental finding that is found out, or the oxidative stress parameters, very rarely we get it done with respect to this thing. And homocysteine, this is done with respect to the people who are at risk, and in the referral centers, the homocysteine estimation is done. Otherwise, there are indications where the homocysteine needs to be done and the clinician had to interfere in estimation of this homocysteine, where people more than 40 years, a person who is diabetic, who is having malnutrition, particularly when we observe the folic acid and vitamin B12 deficiency, because the folic acid and vitamin B12 are the one that is involved in the conversion of the S-adenosyl homocysteine to homocysteine and homocysteine to methionine. So this cycle, the S-adenosyl methionine cycle or the methionine metabolism, which where the homocysteine is synthesized, so for which we need vitamin B12 and folic acid, where the entire folic acid gets trapped as the methyl tetrahydrofolic acid, where we call it as the methyl trap hypothesis or the folate trap hypothesis, where the entire folic acid gets trapped there. In this condition, the homocysteine do not get converted into methionine and the concentration of the homocysteine gets accumulated. This accumulated homocysteine often will lead to constriction of the blood vessel, leading to decreased blood flow further and leading to anoxic condition further in the blood vessels, particularly the smaller arteries such as the cerebral arteries, the coronary arteries, the renal arteries, the peripheral arteries. So these are some retinal arteries. So these are some of the arteries where there will be increased accumulation of the homocysteine, leading to constriction of the blood vessels and further decrease in the blood supply. So the universal classification does, with all these things, the universal classification classifies the myocardial infarction into two types, that is type 1 myocardial infarction and type 2 myocardial infarction, where in type 1 myocardial infarction there will be a plaque rupture, erosion with occlusive thrombosis, and plaque rupture or erosion with non-occlusive thrombosis. One of these two things do happen with respect to the myocardial infarction type 1, whereas in case of type 2 myocardial infarction, there may be atherosclerosis and oxygen supply or demand imbalance. There will be recession between the supply to the demand of the oxygen, where there will be anoxia and anoxic spells, leading to anaerobic glycolysis further in the blood vessels, leading to vasospasm, coronary microvascular dysfunction and occlusion, and non-atherosclerotic coronary dissection, oxygen supply or demand maintenance alone. These are one of the four factors that are going to implicated with respect to the myocardial infarction type 2. And it is the homocysteine which has been identified, or the hypertension or the oxidative stress parameters which are implicated with respect to the type 2 acute myocardial infarction. Next slide, please. The shortness of breath profile that I have mentioned earlier, where here the patients with the myocardial infarction, once they report to the casualty or to the emergency medicine department, so the patients with heart conditions experience shortness of breath every day. With a short stretch of walking in the life, the person feels breathless with a retrosternal chest pain radiating to the left arm, radiating to the ear, left ear, even to the neck, with sweating. So where a person cannot move further. So these things do happen because of the anaerobic condition that is going to be created with respect to the coronary arteries. So this will lead to further aggravation and deprivation of blood supply and oxygen supply to the cardiac muscle. So the cardiac conditions, particularly the angina, which is nothing but the chest pain, heart attacks, heart failure, particularly the congestive cardiac failure, where we observe this particularly with respect to the myocardial infarction, with respect to the hypertension and abnormal heart rhythms, which is a cause or consequence of the myocardial infarction, atrial fibrillation. So these are the factors which may lead to shortness of breath. So in these conditions, when we do the CKMB estimation, the myoglobin estimation, the troponin I estimation, the brain natriuretic peptide estimation, some of the parameters which are included under the SOB profile. So the reference range of the SOB profile of our hospital setting is also being shown here. So next slide, please. So this is the first step that we do in our hospital setup whenever a patient comes here to the casualty. So these are the 5 parameters that we do with respect to the SOB profile. As I mentioned, the time of intervention is very, very, very important with respect to the myocardial infarction. The marker enzymes with their time of release after the myocardial infarction, the mean peak time and the time of return to the baseline are all being shown here in this table. The biomarkers, some of the important biomarkers such as the troponin I is the one that is used in the diagnosis of the myocardial infarction. So the time of release of the myocardial infarction is 3 to 12 hours. Even though the CKMB, the myoglobin, all the other parameters are there, troponin I plays a very important role and plays a prime role in the diagnosis of the myocardial infarction. The CKMB has got its own limitations. The myoglobin also has got its own limitations. So together the myoglobin and CKMB may give us a clue that the person is having myocardial infarction because there are various confounding factors that may interfere with the altered levels of this myoglobin and CKMB. So following which the LDH estimation has to be done, which usually will be elevated once the patient has had MI 12 to 24 hours after the causation of the myocardial infarction. When we estimate the LDH, or after 24 hours, the AST will get elevated. So hard fatty acid binding protein is the one which gets elevated 1 to 5 hours, but the limitation of this is it's very rarely being done in majority of the hospitals. The routine investigations that are done includes the cardiac troponins, myoglobin, CKMB, LDH, myoglobin, and AST. However, when compared to these parameters, cardiac troponin I plays a very important role and plays a key role in the diagnosis, early diagnosis, particularly early diagnosis, which will be released into the circulation in 3 hours and may stay up to 12 hours in the circulation. The peak of which will get elevated in 24 hours. That is the reason in case of any myocardial infarction, every 4th hourly estimation of this cardiac troponins plays a very important role in the diagnosis of myocardial infarction. And further, after 5 to 10 days, it has to reach to the baseline. Otherwise, it means that there is a second chance of the person getting the myocardial infarction. Subsequently, after 24 hours, the person may get myocardial infarction. So that is why we have to keep the patient for 5 to 10 days under observation, and we have to get these investigations being routinely done every 4th hourly in the acute phase, which we consider it as 24 hours for the myocardial infarction, because each disease has got its own acute phase. For the myocardial infarction, we call it as 24 hours is the critical hours for the golden hours in the management of the myocardial infarction, and till the values may get elevated up to 5 to 10 days. So this is one of the crucial time where we need to monitor the patient with respect to these parameters. Next slide, please. Next slide. So, as I mentioned, the troponin I, creatine kinase. So this is the total creatine kinase which exists in 3 forms. CKMM, which is specific for the skeletal muscle. CKMB, which is specific for the cardiac muscle. CKBB, which is specific for the brain. The myoglobin, which has got its own limitation, where it helps in storage of the oxygen in the muscle. So if there is any damage to the cardiac muscle, what will happen? So the storage, the transportation of oxygen is done with the help of hemoglobin, and storage of hemoglobin is done with the help of myoglobin. So this myoglobin cannot store further the oxygen, and it may lead to anoxic spells in the cardiac muscle. So it may happen even in the skeletal muscle, because the myoglobin is also present in the skeletal muscle, and it may get released into the circulation and may give false positives. The hard type fatty acid binding protein, LDH and copeptin, these are some of the serum markers that is being estimated. LDH has got its own limitation, such as any anaerobic conditions. If a person is fasting, if a person has done exercise, So then or if the person is having myositis, or if a person is having any of the skeletal muscle disorders, even then the LDH values may get altered. So next, the heart type fatty acid binding protein, it has got its own limitations, and still we need to evaluate and we need to confirm by plotting an receiver operating curve compared with the other parameters. The copeptin is still a research molecule that needs to be addressed. Next slide, please. The official website of the United States of Government of United States of America, National Institute of Health, National Library of Medicine, National Center for Biotechnology Information. Next slide, please. Has created a consensus document and has proposed that the European Society of Cardiology, American College of Cardiology Foundation, American Heart Association, and World Health Federation, all these people have come to a consensus and they have released a document stating that the acute myocardial infarction needs to be diagnosed in several ways, but mandatorily it should include the cardiac enzymes. So even though, as I mentioned, the ECG plays a very critical role, and the ECG needs to be read with under the mirror of the clinical signs and symptoms. However, these enzymes do not mislead us as much as the ECG misleads us, because ECG has got its own limitations, whereas these cardiac markers such as the myoglobin, CK isoforms, troponin, CKMB, particularly the isoform of the CK, and various other markers comes as handy in the early diagnosis and management of myocardial infarction. That is why the consensus document that has been released states that the acute myocardial infarction needs mandatorily to be diagnosed by estimation of the cardiac enzymes as early as possible, and taking that as the baseline, and we need to do the follow-up every 4 hours or at the time of discharge. We need to see that, so it has to reach the baseline of the biological reference interval that we come across for these parameters. And when we do this troponin, if any elevation more than the 10% of the CV, coefficient of variation, or 99th percentile, it means that the person is having myocardial infarction. Again, depending on the values that we get, we can classify it as micro myocardial infarction, or is it a very large myocardial infarction, an exhaustive myocardial infarction. We can classify it. Next slide, please. Detection of a rise and or fall of the cardiac biomarker values, preferably the cardiac troponin, with at least one value that we take above 99th percentile of the upper reference limit that I have shown here at the in the x-axis of 7, 8, and 9 in the x-axis that we are observing here in this graph, in the upper graph, and the multiples of the upper limit of the normal, where the 1 is considered as the cutoff for it. The 99th percentile is considered that above this is considered that the person is having myocardial infarction. At least one of the following changes should be there. There is symptoms of ischemia, new significant ST to T wave changes, where there may be T wave elevation, which you are seeing here. The normal ST-T changes that you are seeing here, normal, compared to the acute ST elevation, hours after which, where we can see there is a continuous elevation of the T wave changes, and T wave inversion may be there, or ST normalizes, but the T wave will be inverted once the person who had myocardial infarction. And these T wave changes will persist years together. However, the enzymes will return back to the normal. So this is one of the confusion which a clinician will have. This T wave inversion is the one where the clinician will have a confusion that is it a recent MI or is it an old MI? If it is an old MI, how old it is? Is it 1 hour before, or is it days before, or months before, or years before? Because this T wave inversion persists throughout the life of a person who ever had myocardial infarction. So these confusions are overcome with the enzymes estimation, such as the troponins, CKMB, LDH. All these things will overcome these T wave changes and other things. Development of pathological Q waves on ECG is another important finding that we observe with respect to the myocardial infarction. So the imaging evidence of a new loss of viable myocardium or new regional wall motion abnormality is another finding that we observe, and identification of an intracoronary thrombus by angiography or autopsy findings stays a mainstay in the diagnosis of myocardial infarction. Next slide, please. The preferential use of cardiac enzymes, the morbidity and mortality, early diagnosis and management of acute myocardial infarction insists that the cardiac enzymes isolated elevation or with symptoms of ischemia is suffice for diagnosis of acute MI. However, the ECG with clinical findings, with enzyme estimations, with the cofactors, comorbidities, and various other things that we observe, such as the diabetes, hypertension, so the profession of a person, the lifestyle changes that he is having, the dietary habits, all these things help us in early diagnosis of the myocardial infarction. What are the characteristic features of an ideal cardiac enzyme or a cardiac biomarker? So the cardiac biomarker or a biological marker shall be highly specific. It should be highly sensitive, easily detectable, early detectable of the disease process, and it should be affordable by the patient and should be done by any of the technician, preferably the point of care testing, which is done next to the patient at the site of the patient. Bedside investigation needs to be done, and further quantification can be done by drawing the blood sample once the diagnosis has been done and the treatment has been initiated. So the earlier biomarkers, the early biomarker that has been done as a point of care testing shall enable the clinician to draw the blood and send it to the laboratory for further diagnosis and quantification. Next slide, please. These cardiac enzymes include several intracellular myocyte components which are found in the serum, which are measured under circumstances such as myocardial ischemia, trauma, and or myocarditis. In clinical setting, elevation of the enzymes in serum plays a very important role in the diagnosis of myocardial infarction. And as we all know, and I have mentioned, troponin, most commonly used cardiac enzyme for the diagnosis of myocardial infarction. The other markers may also be helpful. However, these should be considered as a second line of investigations compared to the troponins. Next slide, please. The preferential use of cardiac enzymes. Next slide. We are going to the previous slide. Next slide. Next slide. Next slide. The specimen requirements, previous slide. Previous. Yeah. Previous. Yeah. The specimen requirements and the procedure. So this is the point of care testing that I have been mentioning. So with a slide, we can do these investigations where just 2 to 3 drops of serum or plasma is enough, or the whole blood is also enough for it. So for which there will be a well in the slide, to which we need to add 1 drop of the buffer, and we have to observe for the various bands. So the positive band and the negative band. So this will give us a clue that above or below, if the presence or absence of the band will give us above or below of which is an indicator whether the person's values are elevated or not. No doubt, it is a rapid test for the estimation of myoglobin, CKMB, and troponin I, but the exact quantification to identify the extent of myocardial infarction, the damage that it has caused, the quantum of the clot that has been blocked in the coronary arteries, for all these things, we have to take the laboratory help and we have to do the quantification of these parameters, particularly the troponin I. Next slide, please. Next slide. Among the 3 troponins that we know, troponin C, troponin T, and troponin I. Troponin I is cardiac specific. Troponin T is found in both cardiac and skeletal tissue based on the subtypes, and troponin C is present in both cardiac and skeletal tissue. However, many of the queries that we get from the clinician that can we get troponin T, can we get troponin C for myocardial infarction? Yes, no doubt, we can do it. However, the troponin I is specific for this cardiac tissue, hence the troponin I plays a very important role. So we all should know that these parameters are tissue specific. So troponin I is specific for the tissues where it is dependent on the ions, particularly the calcium ion and the potassium ions. So the troponin I plays a very important role in the diagnosis of myocardial infarction. So troponins are the regulatory proteins which are there within the muscle, which are specific for the skeletal muscle as well as for the cardiac muscle. They are involved with interaction of actin and myosin contractile proteins, and this contraction to happen with the help of the calcium and various other contractile proteins, including the collagen for that matter. Troponin I and troponin T assays are available. However, the troponin I is specific for the cardiac tissue, and troponin T can also be done, but troponin T levels are very small concentration in skeletal muscle, hence, and it is non-specific for the cardiac muscle. However, the total troponin with troponin I and T will give us a clue like inclusion and exclusion of these parameters in better management and better diagnosis of the myocardial infarction. However, if there is any damage to the skeletal muscle, can be ruled out by doing this troponin T in addition to this troponin I, where when we are suspecting of the pleuritis or when we are suspecting of various other factors where the retrosternal or the sternal muscles and other things which are skeletal in nature, skeletal muscle in nature, if there is any damage to these skeletal muscles in the chest cage, then we can rule out by estimating this troponin I. However, the troponin I is specific for the cardiac muscle, so estimation of this troponin I plays a very important role in the diagnosis of myocardial infarction. Of late, from the year 2017, we have come out with highly sensitive troponin assays, which are newer and were first approved by United States of America for clinical use in 2017. And this can detect the troponins which were once considered to be the biological reference interval, so which may become pathological. So these pathological changes, pathological values can be detected with the highly sensitive assays of this troponin I. Next slide, please. There is a hand raise by Shashidhar KN. Yes, sir. A query where Shashidhar KN has raised his hand.
Yeah, sir, what we'll do, it was raised a couple of minutes back. What we'll do, we will take the question and Q&A session once you complete it.
Yes, sir. Yes, sir. Yes, sir.
Thank you. Thank you, sir.
That will be nice. Great. Thank you. The troponin methodology that is involved includes the slide method, that is the point of care testing. Immunoassays can give false positive with antibody cross reactivity. So several troponin assays are available and the levels cannot be compared across the assays. As we all know that any biological marker or method dependent, the biological reference interval or the values that we give are method dependent. For example, the simple blood glucose estimation that we are doing in the routine laboratories, which includes the three enzymes, that is the glucose oxidase peroxidase, or the hexokinase method, or the glucose dehydrogenase method that we are doing. Each method that we do for the estimation of blood glucose has got its own positiveness and negatives. That is, it has got its own limitations and it has got its own biological reference interval, similar with respect to the troponins. Whatever the methodology that we are doing, whether it is by the immunoassay or by the mono antibody binding assays or any of the other methods that we are doing, it has got its own limitations. The older assays detect troponin elevations within 3 to 4 hours of the myocardial infarction and peaks at 24 hours. However, there is a recommendation by the American Heart Association that the troponin measurement needs to be repeated 6 to 12 hours, preferably as soon as 2 hours after the basic investigation, the first investigation that has been done once the patient has reported to the casualty or to the emergency medicine department. The newer assays includes the high sensitive assays where it detects the troponin elevation sooner and vary by assay. Next slide, please. The cardiac troponin I fast test kit, where we use the standard colorimetric card and the biological reference interval, the various bands and other things, the color intensity. So the biological reference interval is expressed in nanogram per ml. So all these things are being shown in this table. Next slide, please. The biological variability and kinetics of the cardiac troponins. Several assays are available for troponins. Specific testing information is proprietary information of the service providers. So the various service providers, they have got their own information with respect to these cardiac troponins, and it is a proprietary information of the service providers, and they varies by the assay. However, whatever the method it may be, any of the value more than 99th percentile are considered as positive and may vary by assay and institution. So this percentile has to be determined by the diagnostic laboratories or by the treating physician himself. So where we need to take the 99th percentile as one of the marker for early diagnosis and management. So the details are being shown here in this graph. So the time from the onset of symptoms to hours in the x-axis, and cardiac troponin, that is particularly the troponin I, has been shown on the y-axis. And we can see here the chronic myocardial damage or the injury with the 99th percentile increase in the values, more than 99th percentile increase, that is more than 1, will give an indication that the person is having a severe and acute myocardial infarction, which needs an early intervention and management. Next slide, please. So in most of the clinical settings, cardiac troponin is the cardiac marker of choice. It's an enzyme of choice, and other enzymes should not be done routinely. The reason why we need to consider the troponin as one of the best indicator for the myocardial infarction is that it is more specific and more sensitive to the cardiac injury. Nearly all false positive troponins are limited to the antibody cross reactivity within the testing assay, as troponin is not released from the damaged skeletal muscle because it gets accumulated there and gets degraded there itself. CKMB is released from the skeletal muscle and can lead to false positively elevation. So these are some of the limitations of the other parameters. Thus, the troponin is one of the best marker which I can say as on date, and more troponin is present than CKMB in per gram of the myocardial tissue. That is the reason why troponin is better compared to the CKMB. This has been proved by plotting a receiver operating curve and comparing this troponin with the cardiac marker, that is the CKMB, which was a traditional marker. So somewhere some 10 years back, so 10 to 15 years back, CKMB played an important role in the diagnosis of myocardial infarction. Now this has been overtaken by the troponins, where this has been proved by plotting an receiver operating curve comparing this troponins with the CKMB. Next slide, please. The sensitive cardiac troponin assays, the biological reference interval for the cardiac troponin I is 0.4 to 40 nanogram per ml. Troponin T, it is 0.01 to 25 nanogram per ml. However, the limitations I have mentioned. Cardiac troponin T is non-specific for cardiac muscle, as it is distributed both in skeletal as well as in the cardiac muscle. However, the troponin I is specific for the cardiac muscle, as it is highly concentrated in the cardiac muscle and more than 99th percentile in case of suspected coronary artery disease or people at risk of cardiac injury. So estimation of this troponin I will give us a clue that the person, and this can be considered as that the person is prone to get myocardial infarction, and it can be used as both the diagnostic as well as a prognostic marker. Next slide, please. The testing methods that are available includes the ELISA method, where the principle is based on capture of the antibodies, particularly the monoclonal antibodies are the one that has been used for this troponin I estimation. To increase amount of protein captured and labeled, more than 2 antibodies are used, and detection methods and calibration also vary. This is one of the limitation of this ELISA method with respect to this cardiac troponin, that is the troponin I. Next slide, please. The interfering factors with respect to the troponin. It doesn't mean the troponin I is the leader of all the cardiac markers. It has got its own limitation. For example, the renal diseases can lead to chronically elevated troponin levels in these people. Most common cause of false positives is the immune cross reactivity with the assay, where the immunocompromised people, particularly the diabetes, HIV, leprosy. So these are some of the conditions where we should be very careful when we are interpreting these troponins. And people with malnutrition, people with ketoacidosis, people who are in coma, people in whom there is myocarditis or in whom there is myositis. So these are some of the limitations where we may get false positive results with respect to the troponin I. So these things also to be ruled out whenever we are interpreting the troponin values. Next slide, please. So with this brief about the troponin I and troponin T, and troponin C, so let us further continue with the CKMB. CKMB, as we all know that it is an isoform of the creatine kinase, where the creatine kinase is the enzyme which is involved in the phosphorylation reaction of the creatine to get converted into creatine phosphate. And this creatine phosphate reaction majorly it happens in the skeletal muscle and in the creatine synthesis, where further this creatine phosphate, this reaction is done with the help of creatine phosphokinase or creatine kinase. And this creatine that is synthesized will undergo with the addition of the water molecule, the phosphate group that is there in the skeletal muscle, creatine phosphate is a high energy molecule which is required for the muscle activity, starting from tongue to the skeletal muscle to the cardiac muscle, even to the smooth muscle. So this creatine phosphate is required, where it provides the energy for the movement of these muscles and other things. So once this creatine phosphate is synthesized, there will be dephosphorylation with the addition of the water molecule, or with the help of the enzyme, it gets converted into creatinine, and creatinine is a water-soluble molecule and it can get excreted through the urine. However, in the middle step of this, the creatine phosphate that is formed requires an enzyme, that is the creatine kinase enzyme, which is otherwise also called as the creatine phosphokinase. So this creatine phosphokinase has got three isoenzyme forms: CKMM, CKMB, and CKBB. As I mentioned, that CKMM is present around 85% in the skeletal muscle. Next comes the CKMB, where it exists in 5 to 10%, particularly in the cardiac muscle, and CKBB, which is there around 1% in the brain. So among these three isoforms, which is specific for the cardiac muscle is the CKMB. CKMM is elevated in case of skeletal muscle injuries. However, preferably and preferentially to diagnose the myocardial infarction, it is always better to estimate both CK as well as CKMB, and it is better to take the ratios of CK to CKMB in better diagnosis of myocardial damage. Prior to troponin, CKMB was the main cardiac enzyme that was used for the diagnosis of myocardial infarction. However, CK is found in all muscle and is non-specific for the myocyte. So, the ratio proportions of the CK to CKMB plays a very important role in the better management and diagnosis of the cardiac damage. Next slide, please. CKMB, the biological reference interval is around 0 to 25 units per liter and is specific for the myocardial infarction. It is found in the serum. So within 4 to 6 hours after the onset of myocardial infarction, it gets elevated, and it can take up to 12 hours in few people where there is already the damage has happened, or in people where the phosphate plays a very important role in the activity of or in the estimation of this CK and other things. So CKMB levels return to baseline within 36 to 48 hours, and still it is used to assess reinfarction after the intervention. Elevations in CKMB must be interpreted with caution in situations where skeletal muscle injury or the disease is also suspected, as CKMB is released from the damaged skeletal muscle. Next slide, please. As I mentioned, the ratio, the CK to CKMB ratio is preferable to report a ratio of CK to CKMB to CK. Ratio will ascertain whether elevations in CKMB are increased to an extent greater than what would be expected with skeletal muscle injury alone. So the ratios play a critical role in better diagnosis and management of myocardial infarction. However, compared to this ratio calculation, all this laborious and cumbersome work that we need to take with respect to this, so troponin is preferred in almost all situations where it is available for use. Next slide, please. So this is the value that we can see here. So the CKMM values in case of acute myocardial infarction is strongly elevated followed by the CKMB, where the CKMM to CKMB or the total CK to the CKMB levels plays a very important role in the early diagnosis and management. As we all know that it is the before they used to think that it is the CKMB is the first enzyme which used to get elevated within 24 hours after the onset of the myocardial infarction, followed by AST, followed by LDH. Now, with the advent of these troponins are elevated within 4 to 6 hours after the myocardial infarction, at the most by 6 hours. So, troponin plays a very critical role and important role in the diagnosis of myocardial infarction, followed by CK. As I mentioned, CK also has got its own limitations. LDH has got its own limitations. AST is dependent on the liver and functions of the liver, as AST, as we all know that it is the aspartate transaminase which is involved in the transamination reaction, which is a pyridoxal phosphate dependent reaction. So, estimation of troponin plays a very important role, and myoglobin, no doubt, it is one of the earlier markers where we can diagnose the myocardial infarction within hours after the onset of myocardial infarction. However, the myoglobin levels, also the myoglobin estimation also has got its own limitation, because the myoglobin is involved in storage of the oxygen. Any damage to the muscle may alter the myoglobin levels. So, the myoglobin estimation can be considered as a parallel and as a supportive marker to the troponin compared to the direct estimation of these markers. However, when compared to these markers such as the CKMB or the total CK or AST as well as LDH, the troponin levels plays a very important role and pivotal role in the diagnosis of myocardial infarction. Next slide, please. The test procedures for CKMB or the CK. So this total CK can be estimated, quantification. The activity of the enzyme is the one where we will be doing estimation in case of the routine laboratories, and it is not the mass that we are going to do. Mass can be done with respect to the mass spectrometry and various other in case of research, or if you want to find the mass of the enzymes, you can go ahead with it. However, it is the activity of these enzymes which will help us to find the conversion of the substrate to the product, that is the conversion of creatine to creatine phosphate. The phosphorylation reaction that is happening can be found out with the help of finding the activity of these enzymes. However, the isoenzyme form, the CKMB, plays a very important role, as I mentioned, among the 3 CK isoforms, that is the CKMM, CKMB and CKBB, and this can be categorized by with the help of electrophoresis. So the clinical laboratories use the agarose gel or the cellulose acetate electrophoresis. However, with the advent of various instrumentation that has been done, the CKMB activity can directly be estimated among the total CK. The CKMB activity can be estimated, and this quantification by elution of the electrophoretic bands can be done with the help of densitometry or with the help of fluorimetric or spectrophotometric techniques. Column chromatography and radioimmunoassay can also be used for quantification as well as to find out the activity of these isoenzyme forms of the CK. Next slide, please. The myoglobin, as I mentioned, it's a very small heme protein with a molecular weight of 17 kilodaltons, found in many tissues, and it is present in the cytosolic compartment of the cell. Because of the low molecular weight and cytoplasmic location, it reflects that myoglobin is rapidly released into circulation, and it has got a very short half-life of 2 to 3 hours, and it can be excreted through the urine. So this limits the use of myoglobin further in the diagnosis of myocardial infarction. So it will be very critical if you do this estimation within 2 to 3 hours after the onset of the symptoms. However, by the time the patient reaches the hospital, and by the time we do and report the parameter, so it may be delayed. So, however, I cannot deny that. So myoglobin cannot be used 100%. It can be used if the patient is brought to the hospital within 2 to 3 hours, or any of the hospitalized patient, if he has any symptoms, and early intervention by the clinician may help in estimation by estimation of this myoglobin in finding out whether the person is having myocardial infarction. Next slide, please. it is released into circulation, this myoglobin within 1 hour, reaches the peak by 4 to 12 hours. However, reaches baseline within 24 to 36 hours. The biological reference interval is 5 to 70 micrograms per liter, a very sensitive molecule with high sensitivity and specificity for myocardial infarction. However, the limitations of which is that it has got a very half-life, a very small half-life, and it has this limits its use as a poor clinical specificity of 60 to 90% in the diagnosis of myocardial infarction. Next slide, please. The test procedures includes the immunodiffusion, hemagglutination inhibition methods, and immunoelectrophoresis. These are the 3 important methods that needs to be done. Next slide, please. Hard type fatty acid binding protein. It's not available in the United States. Still, it is a research molecule there, and we need US FDA approval for it. Once that has been done, then it will be released into the market. However, so now at present, it is a research molecule, and this is used to find out in research studies that it can be used as one of the marker for early detection of myocardial infarction, even preferably before the myoglobin and troponin. Next slide, please. LDH, as I mentioned in the beginning of my presentation, that it is previously used in conjunction with CKMB, and it is an enzyme which is used in the last step of the glycolysis, where it is involved in the anaerobic glycolysis, that is conversion of pyruvate to lactate and lactate to pyruvate, the reversible reaction. And further, this LDH is found in many tissues, and hence it is non-specific and takes several hours after onset of injury for levels to become elevated, because once the anaerobic condition sets in, this enzyme has to be released into circulation, and then only it can be detected, and may take more than 24 hours for this enzyme to be released into circulation, and it can be used for identification. However, these markers initially this has hand-holded the clinicians in diagnosis and management of the myocardial infarction. So, of late, as the advances has happened, now presently we are speaking of the troponin. Tomorrow, who knows, this troponin may be overtaken by various other molecules, such as I mentioned in my previous slide, that is the hard type fatty acid binding protein, may overtake it once it becomes a diagnostic molecule and shifted from research to a diagnostic molecule. Next slide, please. Copeptin, it is a C-terminal end of arginine vasopressor precursor protein. It is released from the pituitary gland during myocardial infarction. So, early rollout strategies using copeptin measurement with standard cardiac troponin assays have not clearly shown any advantage over the troponin alone. Hence, this copeptin has been kept impended till further evaluation and reporting. Next slide, please. To conclude about today's discussion, these biomarkers are used to enhance healthcare team outcomes, particularly the early management, and which will help. As a laboratory people, we will be assisting the clinicians in early diagnosis and management, and particularly with renowned people in the diagnostics and leaders of the diagnostics, particularly the Quidel Ortho people, with whom we are happy, and we are doing and we are catering to the needs of the clinicians of our institution, and also to the adjoining, as our institution is present in the eastern part of Karnataka with linkages with the Tamil Nadu as well as Andhra Pradesh, and we are one of the healthcare leaders, I can say, in this area. We are providing service to the Tamil Nadu as well as to the Andhra Pradesh and to the population of Karnataka, the Kolar district. So the myocardial ischemia is a medical emergency where an urgent basis, the diagnosis needs to be done, the treatment protocols to be begun without any waste of time. Atypical presentations, serum markers help identify the problem. An accurate and sensitive cardiac serum marker, particularly the cardiac troponin, can play physicians take steps to prevent damage to the myocardium and save the life. However, the troponin elevation should always be to be the result of the myocardial damage, and it has got its own limitations, and those limitations also to be considered clinically as well as biochemically before coming to any of the conclusion. However, the treatment has to be initiated and it needs to be started, and treatments other than troponins, tests other than the troponins to be considered only on need based, particularly the other parameters such as the myoglobin, the CKMB, the LDH, the AST, and heart fatty acid binding protein. However, this HFAVP is still a research molecule and it needs to be further evaluation. Next slide, please. Next slide. So these are some of the references that I have used as an evidence for all the talk that I have given. So next slide. Thank you.
Thank you so much, Doctor. Such an enlightening presentation, and I think you explained in simple, and it's a very like how we are all looking in that manner. Thank you, Doctor. Any question and any questions?
Morning, doctor, and thank you for providing the wonderful insights on the myocardial infarction as well as on the biomarkers to be used for detecting the myocardial infarction. I have got one question. While the process of arteriosclerosis is a gradual process, it all depends upon the lifestyle of a person, whether how faster the arteriosclerosis is happening. My cue to you is, can troponin, high sensitive troponin, can get included in the health profile, where a person does a regular health checkup and based on the arteriosclerosis hardening, maybe 50% or 60% blockage, can the level of troponin also get elevated?
So these cardiac biomarkers needs to be read under the light of the clinical signs and symptoms. So once the person is having any of the chest pain or any of the signs or the symptoms that I have mentioned in my previous slide, such as the retrosternal chest pain, radiating to the left arm, radiating to the left ear, back to the shoulder blades or to the abdomen. So then only these cardiac troponins has to be estimated, number one. Number two, the lipid profile and other things are one of the marker parameters where we need to do in case of the high risk people or the people who have crossed more than 40 years. Before they used to say that the person who is more than 50 years needs to be done. Now the World Health Organization, American Diabetic Association, they have come out with the guidelines that it needs to be done in any of the persons who is more than 40 or 45 years of age, and every annually we need to do it. And in addition to these lipid parameters, so this gives us a clue how much the lipid parameters are getting varied. However, we are doing the total LDL. So it is preferable if you do the oxidized LDL rather than this LDL alone in the estimation, in the to draw a conclusion of chance of getting myocardial infarction. However, the troponins has to be done just with elevation of the lipids and other things doesn't give a clue that troponins needs to be done. So troponins will come into picture only when there is a damage to the cardiac muscle. Then only the troponin I needs to be pitched in and it needs to be estimated. So the lipids, the blood glucose estimation, all these parameters are mainstay in a routine follow-up visits and for implementing the lifestyle modifications and other things, and in prevention of the atherosclerosis and other things. So these things will help. However, the troponins needs to be done once the consequence, it is a consequential marker rather than the causative marker. So that we need to keep in mind always.
Thank you, doctor. Thank you.
Thank you.
Sir, I have one question. So in your kind of clinical setup, so what is the percentage of the patients where the clinical symptoms are there, but ECG is not either T wave or this is not elevated, but the troponin are elevated. So what is the percentage of the cases we see like this, doctor?
Yeah, this we consider it under the heading of a non-ST elevated myocardial infarction. Non-STEMI, we call it as non-STEMI. So this is one of the challenges majority of the clinicians do face. So there are few challenges with respect to the myocardial infarction diagnosis and management. Say for example, a person who is a diabetic. So in these people, often they may not notice the chest pain. However, they may have this associated findings such as the adrenergic findings, such as the sweating, cold, clammy skin, all those things will be there, which may confuse us with hypoglycemia. However, the inside, the setting in of the cardiac damage would have started, and the adrenaline would have released and leading to these things. So in these people, we should be very careful. This is one of the confusion that will happen. The other confusion is, as I mentioned, and as you have also raised it, sir, regarding this non-ST elevated myocardial infarction. So this non-ST elevated myocardial infarction do happen particularly in people who are having the metabolic syndrome. In these people, so the routine estimation of the troponins and other things plays an important role. ST elevated myocardial infarction, it is a direct view that it is something like a seeing with a mirror. So this is one indirect way that non-ST will be there, based on the clinical finding, based on the risk factors, based on the person's habits and other things, we need to diagnose where the ST elevation may not be there, but myocardial infarction would have set in. In these people, the troponins plays a very important role.
Okay. Thank you, sir. Thank you, sir.
Dr. K, here's Dr. Shashidhar. Thank you so much for the excellent presentation, and there are a lot of key learnings for me as well in this, especially the differentiation of AMI 1 and 2. I won't get into details of that, but more than this, another one I wanted to know was about the questions that I get when I meet doctors is the difficulty in diagnosing reinfarction. So as far as reinfarction is concerned, we are led to believe that CKMB is the choice of test for reinfarction. Is it true? As per your opinion, we want to know between troponin I and CKMB, or is there any other marker which is good to use for detecting reinfarction, doctor?
I am of the opinion that troponin I is a better marker compared to the CKMB, because the National Institute of Health, they have recommended that the troponin, once the patient gets admitted, we have to do the troponin I estimation, needs to be repeated 2 hours after that, followed by within 6 hours, followed by daily estimation, and up to 15 days. So this 15 days is considered as the acute phase for this myocardial infarction. So within this 15 days, if it doesn't happen, then we can assume and presume that the person may not go in for reinfarction unless otherwise there is any stent and other things that has been put to the patient. And if there is any stent rejection, or there may be a reaction of the stent and other things, graft rejection and other things might have happened. So in these people, the chances of getting the reinfarction with a graft rejection is roughly around 1%. This is the, as on date, the statistics that we have.
A very important point and learning for me is you said that when the patient is there in the hospital for more than a week or say up to 15 days, every day the troponin high has to be done, isn't it, doctor?
Yes, sir. Yes, sir.
Okay, but when I check with the hospitals, they say that the laboratory investigation happens only once or at the most twice for laboratory troponin I, whereas the clinician ends up using the POCT assays more often. So in your experience, do the clinicians keep using this for 15 days, only the POCT, and they don't use the lab one? Because as per the lab records, we don't see that the clinicians really order this test every day for 15 days, doctor.
See, this POCT is for an immediate diagnosis and for the point of care testing. So this cannot be construed in the follow-up or for any of these things. It is for the self-monitoring, I can say, similar to that of the glucometers that we use. So the glucometer values cannot be used for fixing of the insulin or anything of that sort. For fixing of the insulin, how we are using the laboratory data. Similarly, for taking the clinician to take any decision regarding the discharge or in the management, it is always the laboratory investigation of the troponin, and at least once in a day, the troponin has to be done for 15 days, so that, and we need to plot a graph, like the values, how it is happening. If there is any decrease in the values of the troponin reaching the baseline of less than 99th percentile, then it means that the person is improving and there is no chance, the limitations of he getting a reinfarction or rejection of the stent or the graft or whatever that has been done is very minimal, so he can be discharged after the 15th day. So the mainstay in interpretation, diagnosis stays with the laboratory. The point of care testing should be done. It is something like less than or more than, or for early diagnosis we have to use. However, the laboratory investigation, laboratory estimation of the troponins are very critical in the diagnosis of myocardial infarction, troponins particularly, to find whether the person is improving or not.
Thank you, doctor. So do I understand from your statement that in your hospital, as long as the patient is there for diagnosis of, after diagnosis of AMI, every day the laboratory troponin I is being done till for a week, for 15
We
days?
are having a tie-up with Narayana Hrudayalaya, RL Jalapa Narayana Hrudayalaya. So we are doing it. This is the protocol that we are following. And usually the hospitals, they will have their own protocols. And this is the standard protocol that what I am mentioning is the standard protocol that has been recommended by the National Institute of Health.
Oh, that's very useful, doctor. Thank you so much.
Thank you. Any more questions? I think we are taking more time what we requested, doctor. I think we can take one last question if anything is there.
So let me take the advantage of asking the last question. That's about the differentiation of AMI 1 and 2, which you very well brought in your presentation, doctor. So between the two, if you compare AMI 1 and AMI 2, in your presentation, you said that AMI 1 is more caused by the plaque, which is to do with the lipid methodology, etiology, whereas AMI 2, as I understand, may not be to do with the lipids at all. So a few questions come to my mind. One is, what is the incidence of AMI 1 and 2, which is more common? And as I understand, since lipids may not be involved in AMI 2 is more difficult to diagnose and treat. So can we hear from you about the incidence as well as the what is the approach for differentiating AMI 1 and 2 practically in your hospitals?
See, here the urbanization and the rural population plays a critical role here. Majority of the rural population, unless otherwise, if there is any genetic defects with respect to the lipids and other things like hypercholesterolemias or family history of diabetes, these things are smoking history, all these things, the chances of getting type 1 myocardial infarction or type A myocardial infarction is more. With respect to the urbanization, particularly the sedentary lifestyle, then binge eating, eating of the junk food, then the lifestyle modifications, all these things plays a very important role in the causation of type 2. So urbanization and rural population, so I can contribute more of this type 1 to the rural population rather than to the urban population. Urban population, the stress or particularly the oxidative stress or maybe because of the lifestyle and other things that they follow, the type 2 can be implicated with respect to the urban population. Next, with respect to the age and other things, the generation and other things. So what we call the people who are more than 50 plus, these are the people who are prone for this type 1, I can say, rather than this type 2, because of the most common debilitating and chronic diseases where the person may not go ahead with the exercise and other things. There may be lipid accumulation. Again, these are the controversial statements which needs to be studied in depth before we draw any conclusive remarks regarding the distribution of this type 1 and type 2. However, maybe with proper data and other things, shortly we may get a derivation of the data with respect to this type 1 and type 2, sir.
For the use of biomarkers, clinical biochemistry markers, which are the markers which play a role in differentiating AMI1 and 2, doctor?
Lipid estimation, diabetic status, homocysteine levels, folic acid estimation, vitamin B12 estimation, then oxidative stress parameters. These are some of the parameters which will help us in classifying type 1 with the type 2.
So in the algorithm, the first thing they will look at is the LDL level. If it is high, they may suspect AMI1. Is it that case, or they will look all the parameters?
Increased LDL, decreased HDL, increased triglycerides, increased blood glucose, increased HbA1c. These are some of the parameters which are implicated with respect to the type 1.
Okay, so if these parameters are normal and not suspicious, then they will go for the other parameters.
Other parameters where homocysteine, folic acid, these are the parameters, and vitamin B12, these are the parameters which we need to estimate.
Okay, thank you, doctor. It was useful.
Sir, this last one question which posted, sorry, two questions, if you are okay, sir.
Please.
So there are two questions are there. One is that I think you have already addressed it, but I think in short form will be very helpful. How do we differentiate chest inflammation versus ischemia? That is a one question. And the second question is your suggestion on using HS troponin I for risk stratification, as it may help to segregate normal person in a high risk or moderate risk zone. So these are the two questions, doctor.
Okay. Let me answer the first question. That is, can you please repeat the first question?
Yes.
Inflammation, right? It is related to the inflammation.
How do we differentiate the chest inflammation versus ischemia?
Chest inflammation is a different entity here altogether. Chest inflammation is a sign where there will be redness and there will be pain, all those things will be there. And chest inflammation is a broad term. The inflammation with respect to the myocardium is different, where we call it as myocarditis. So the myocarditis is inflammation of the layer covering the heart. So this is with respect to the myocarditis, where there will be pleuritic pain associated with severe chest pain, mimicking the myocardial infarction, all those things. The myocardial the difference between the itis and the clot formation is inflammation. It is linked with the pain, whereas the myocardial infarction, it is due to the decreased blood supply to the further of the myocardium, damage to the myocardium, increased lactic acid. This increased lactic acid, there is an hypothesis that has been framed there, that is the increased lactic acid accumulation there. That is the Warburg's hypothesis that has been proposed there, where it will lead to change in the acidic environment itself in the myocardium, where the lactic acid accumulation will lead to increased acidosis there, causing the pain and other things, stimulation of the nerves, nerve cells, nerve filaments there. So this is the thing that is linked with the infarction and inflammation. Inflammation is an inflammatory sign with respect to the myocardium, that is the myocarditis that is going to happen, whereas the coronary arteries there. Coronary artery blockage can also lead to inflammation there, creating signs of inflammation such as the pain, redness and other things in the myocardium itself. A segment of the myocardium itself, there may be an inflammation. So I think this will suffice to the first question.
Yes, sir.
Sorry, sir.
Yes, sir. I think it's clear.
So the second question, it is, can you please repeat the second question, sir?
Yeah. Your suggestion on using HS troponin I for risk stratification, as it may help to segregate normal persons in a high risk or moderate risk zone.
Yeah. The difference between the traditional troponin and high sensitive troponin, the high sensitive troponin, the biological reference interval is different. The high sensitive troponin levels will give, even if it is a minor clot, that itself can be detected with this high sensitive troponin, rather than the traditional troponin, because the traditional troponin, the reference interval is a higher reference interval, whereas the high sensitive troponin, the biological reference interval is very less. So with this sensitivity and more narrower finding of this high sensitive troponin, this high sensitive troponin can be considered, and preferably high sensitivity troponin needs to be considered rather than this traditional troponins.
Thank you, sir. I think sorry to take more time from you.
No.
Your busy schedule, and once again, thanks a lot. It's very insightful presentation. I think our team, the number of questions which posted is a example that how they are involved in your presentation. I think it's your presentation it's phenomenal, sir. I think it's extraordinary. Once again, thanks a lot for your taking time from your busy schedule and taking a session for our internal team. Thank you, sir. Thank you.
Thank you, Dr. Santosh. Thank you, Santosh. Thank you, Tamal. And I should thank all the people, whoever have given me an opportunity for my presentation. And I should thank Mithun for contacting me and asking me for this. So I thank all the people who have attended, and hope I didn't take much of your time boring you. And these are some of the things which practically I have come across in the diagnostic laboratory. Out of my experience, some of the things I have quoted, some of the things I have taken it from my clinical experience, some of the things I have got it from the references, some of the things I have got it from the Quidel Ortho itself. I have learned by attending to various webinars and other things that you people have conducted. So, and also the American Heart Association, and also various other webinars that I have attended. Thank you, Santosh. Thank you, Tamal, and thank you, Mithun, and all the people who have given me an opportunity to make this small presentation. Thank you once again. Thank you.
Thank you, sir. Thanks a lot, Mithun, for arranging this session. Thank you, sir. Have a great day, sir. Thank you.
Thank you.
Thank you, sir. We have learned a lot.